Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
It's my privilege to introduce our next speaker, His Excellency Dr. Nathir Obeidat. Dr. Obeidat is the Minister of Health of Jordan and a professor of medicine at the University of Jordan. Dr. Obeidat has had an incredibly distinguished career, having served as chair of the Department of Medicine and Respiratory and Sleep Medicine at the University of Jordan School of Medicine, as well as Dean of the Jordan University School of Medicine. He is a recognized authority in the field of pulmonary and critical care medicine and is widely published in this area. So good morning, Dr. Obeidat. Thank you for being with us this morning and for the opportunity to introduce you.
Thank you, Dr. David, for the introduction, and I would like to thank Mr. Friedman for his excellent talk. It's very nice always to hear from distinguished speaker, and especially when they are talking about medical problems and they are not doctors. It's very nice talk, and I agree with you, Dr. David, about when you stress that this pandemic, we learn from this pandemic that unity and solidarity is important in dealing with this pandemic. We in Jordan try to have different strategies. Actually, initially, we tried to have suppression strategy, and we succeed actually in stopping or even stopping the spread of the disease from March till August. Actually, we have very small number of cases, but actually after that we start having spreading of the disease when we have weak point with our border with Syria, when unfortunately one or two cases enter Jordan from these borders, and then we have spread of the disease from different areas in the north of Jordan to Amman, and after that, unfortunately, we start having what we call it community transmission of the disease in Jordan. I will try to share with you some slides or a small number of slides just to talk about our experience in Jordan. Actually, the objectives of my talk will talk a little bit about the epidemiological status in Jordan and how we take the decision and making decision regarding dealing with the pandemic, the surveillance activities, what we are applying in Jordan about case management, health capacities, immunization policies, what challenges we are facing these days. We have in Jordan, in Ministry of Health, what we call it National Committee for Epidemics, and this committee was in Ministry of Health since 1992, and actually I am a member of this committee since 2002. The Ministry of Health in Jordan, we have the Ministers' Council and National Center for Security and Crisis Management these days, and they are dealing with the pandemic in a good manner. I think we are lucky that we have this Crisis Management Center in Jordan. And at the end, we have National Policy Council. If we're looking to the cumulative number of cases in Jordan, actually, as I said, we have a very small number of cases from March till 26th of August, to when we start having the clusters in the north of Jordan, as I said, and after that, the clusters, one of the cluster in Amman was out of control, and we start having the community transmission. That's why after that, we start seeing that the curve is going in a very sharp ascending manner. Still, if we look to Jordan in the bottom of the picture, Jordan and Tunisia, probably, if we compare it to the other countries of Jordan, we are still the number of cases is not very bad, and probably now we are approaching 72,000 cases in Jordan. If we compare to other countries in the region, still we are okay, but I think we starting having the community transmission few months after they start having this in other countries. This year, again, we see that in August, we have only 841, and in September, still the number is 9. We have probably 9,791 cases, and in October, the number is much, much higher. Probably it's 4 times what we have in September. But looking by weeks, actually, in week 36, we have 644, and we have more than double the cases in week 37, and still doubling in 38, and it's 2.2 more than in the previous week. In 39, again, we have 6,439, which is actually, this one is 2.2. In week 40, 1.4 times the week before, 41, 1.3, 42, 1.2, and in 43 a week is 1.4. Actually, in the last 3 weeks, actually, we see increasing number of cases, but we don't have doubling of the number of cases weekly. If we look to the age distribution for COVID-19 confirmed cases, actually, this is absolute numbers, absolute number for each age group between less than 5 years. We have around 2.5% of the reported cases. From 5 to 24 year of age, we have 35% of the reported cases. Again, if we look to the age group between after age of 60, we start seeing small number of cases. This is probably because Jordanian people in Jordan are young in general, and we don't have all population. And if we look for deaths in Jordan, till now we have around 770 deaths, and unfortunately the death rate is increasing after 24th of September. It's in parallel with the increased number of cases, actually. If we look for by weeks for the death rate, again, we can see that we have almost less than, we don't have doubling of death cases in Jordan, but actually the numbers are increasing every week. If we compare the death rate for 100,000 of population, we can see that the death rate actually is much more in age group after 60 years. 42.1 of the deaths are for this age group. Actually, the average age is 68. And if we compare it to the in the light blue, we can see that there's difference between the death rate compared to the number of cases in for each group age group. So obviously the death is more in the age group after more than 60. Regarding the association between death and comorbidities, at least 33.33 of people, they have one comorbidities, 0.5 two comorbidities, 14% three comorbidities, 2% for comorbidities, and less small number we have 5 comorbidities. So most cases they have at least 2 comorbidities. The positivity about the cases, we can see that till 35 week, we have 0.6 positivity, and in 36 week 36.8. So in the last week, we start seeing that the positivity increase to high percentage. Actually, it's around 13%. This to us is important to see that the positivity is increasing in the last few weeks. This probably is difficult this slide to explain the surveillance cycle in Jordan. Actually, we have a electronic program dealing with this surveillance cycle in Jordan. The time from taking the sample now until we have the result is 36 hours. But the majority of the results it's end with it takes around 24 hours actually, and after that we have problem in talking to positive cases because we have problem around 20 to 25 of cases they don't answer their telephone calls. So actually, this problem, we are trying to improve this, but unfortunately, we can't reach more than 50% of the positive cases. But actually, most we know that the severe cases, they go to hospitals, but mild cases, actually, they stay home without we can't reach them in most of cases. And we have other problem in reporting recovered cases from those who are in home isolation. But we will try to have an assumption formula to decide the recovery of these cases. Regarding our capacity for doing PCR, actually, we have the capacity to have 39,000 cases in the labs, but actually we reached 30,000 yesterday, 30,000 tests, and it's around 70% of our capacity. Actually, all the tests which we are doing for cases are PCR. We approved only the PCR as a diagnostic test for to confirm cases in Jordan. We have a modeling analysis to see what is happening, what we expect to see in Jordan For example, if we have now we have around 3,000 cases, and our admission rate is supposed to be 10%, but in reality, the admission rate is 9%. So, for example, if it's 10%, we expect 300 cases to be admitted daily. We have regular beds at any time is 1,800 beds. For that, we expect that if we have 3,000 cases to have 1,800 beds needed at any point. And actually, we have less than that. We have around 1,600 cases, beds available. But for ICU, from 3,000, if we consider 3% admission in ICU per day, so we expect 90 cases, and half of them, they will need a ventilator for 45 cases. And at any point, probably if we consider the hospital stay 10 days, we need to have 450 ventilators at any point. Of course, if we have more than that, we may have some pressure on our system, because the number of our beds in ICU is 710 beds allocated for treating patients with COVID-19, and we have 1,500, around 1,500 cases allocated to treat patients with COVID-19. So we are okay with 3,000, but after that, probably we need to allocate more beds for to treat patients with COVID-19. We are trying now to have to engage the private sector in treating these patients. We will try to have one good hospital in the private sector. We will start increasing our capacity from 1,500 to 1,700 cases in the next week. We are trying again to in the future to have rapid PCR, to have rapid antigen test, and just to compare this with real-time PCR, we can see that it's sensitive, but it's not. It's actually its specificity is high, but the sensitivity can be moderate. We don't consider this as a diagnostic test, but we may use it as screening test for people in schools and in institutions, or in other groups of population, especially when they are homogeneous group. But till now, we don't have any other test for to diagnose cases other than PCR. Regarding case management pathway in Jordan, actually, it's a complicated slide, but we, after confirming the case, we try to assess severity and classify cases to mild, moderate, severe, and critical. The mild cases, we isolate them at home, but patients with classified as moderate or severe should go to the hospitals. Moderate cases, either they are in normal floors, but when they have respiratory failure not improving by oxygen therapy, we consider them as more severe, and they go to intensive care units. Again, regarding patients with critical cases, actually, when they have when they needed intubation and mechanical ventilation, we consider them as critical cases. regarding definition, we are following the WHO criteria for definition of suspected cases or confirmed and other definitions. For releasing patients from isolation, again, we are following WHO criteria. So after 10 days for asymptomatic cases, we consider them as recovered, and for others who have symptoms, after if they pass 10 days and after that they have 3 days without symptoms, we consider them as recovered cases. We have special home isolation regulations, and actually we start approve home isolation just in September. Before that, we used to isolate in hospitals or confirmed cases, even if they are asymptomatic. We have therapeutic protocol approved by the epidemiology committee and updated from the start of the pandemic till now 3 times. Regarding our designated capacity, and when we have yesterday large number of cases, actually we look to our occupancies, so we can see that regarding regular beds, 45% of the beds are occupied, and for ICU 55%, and regarding ventilators is 30%. We are okay with ventilators actually, and non-invasive ventilation. So what if we have 100 infected cases, 10 of them we admit them to the hospital. Suppose 7 of them to recovered and 3 to go to recovered from the while they are in the floors. 3 of them they should go to ICU, and fortunately one and a half of percent of them they go for ventilators, and large majority of them unfortunately they died, and the recovery after intubation in Jordan is around 70. The death rate is around 75%. We have modeling for COVID-19 in cooperation with Oxford University and WHO. And if you look to the number of the beds and ventilators, we have shortage more in regular beds, more than ICU beds. We have this modeling with them, and actually, if you look to the left side up quarter, you can see that we may have at the end of the year 23.1% of our population probably they will be infected, or they have final attack rate of 23%. And if you increase the mask wearing, this will improve from 23 to 19%. If you look to the daily total cases, the peak will be 30,000. Actually, 30,000 doesn't mean it's different from registered cases or reported cases, because we know that according to this modeling scenario, they reported only 11% from the actual final attack rate. So by this, we can see that the maximum if we don't do anything, or we just close the schools and universities and having one day, sorry, without have lockdown for any at all, we'll have around 3,000 reported cases or 30,000 final attack rate. If we look to the left down, weekend closure will improve the final attack rate from 23 to 17%. And if we apply more, if we are more strict with using mask, this will decrease from 16.7 to 14.8. Actually, we try to look if for 2-week lockdown, and it's okay. It's decreased the number from 3,000 or 30,000 final attack rate to less than 1,000. But the not good scenario is if you have 2 weeks lockdown, then we reopen the school, the final attack rate will be worse, 23.6%. That's why we don't look to apply 2 weeks lockdown, because we know that the compliance of our citizens is not appropriate. So after 2 weeks lockdown, probably we may have rebound attack rate, and actually we trying not to go for 2 weeks lockdown, but I hope we can continue without this scenario. And the death rate actually is by all the modalities, probably it's range from 600 to 1,000 by the end of this year. But looking to the numbers these days, actually we may exceed this more than 1,000. So according to our recommendation that still we need to have strict measures to achieve acceptable level of using mask, and we need to increase our capacity mainly from regular beds. And again, we have to look for possible increasing the number of tests, or probably looking for other possibilities, especially when we reach confirmed cases or cumulative cases that we can't cope according to our capacity. We are looking to increase actually now what we are doing after 10 p.m. We have lockdown after daily after 10 p.m. till 6 a.m. morning. We are looking to increase this time to be from 9 or 8 p.m. till 6 a.m. next day. Regarding the vaccines, and this year we have 5 times flu vaccine given to our citizens. We have around 250 or even 270,000 shots of vaccine. Our population is 10 million. So this is 4 or 5, even more than 4 times that what we use in the last, in average, in the last 5 years. Regarding COVID-19 vaccine, actually, we have an agreement with COVAX for to have vaccine for 10% of our population, and we are looking to have another agreement with other companies to cover in total 20% of our population. So we, although we think we need more than that, but actually we are estimating our estimation to have 1 million of our population to be vaccinated by COVID-19 when it's available. Now what we are looking for is we are trying to have more strict and to enforce people to be compliant with masks, using masks, and to keep physical distancing. We have to increase the effectiveness of our surveillance to improve case management as much as we can, and to upgrade our health system capacities, especially to upgrade intensive care capacity and regular beds. And regarding ventilators, although we are okay, but we are aiming to increase our capacities in high flow oxygen and non-invasive ventilation, and to less extent the conventional ventilators. Unfortunately, we don't use ECMO treatment in Jordan because we don't have an expert team to deal with ECMO. And for now, I will finish my talk, and thank you for listening to my talk. Thank you.
Thank you, Nathir. Dr. Nathir Obeidat. I would like to ask Sue